Hi guys, welcome back to Prague ICU. I'm Mikhail Pazdernik, and in this presentation I will give you the most important information about continuous renal replacement therapy in ICU. Renal replacement therapy can be divided into three main types: peritoneal dialysis, intermittent hemodialysis, and continuous renal replacement therapy. CRRT is then divided to slow continuous ultrafiltration, CVVH, CVVHD, CVVHDF, and SLET. Intermittent hemodialysis or continuous renal replacement therapy circuits utilize the same principles. Blood is removed from the patient, blood is pumped through a filter, and purified blood is then returned to the bloodstream. Intermittent hemodialysis removes large amount of water and solutes in a short period of time. In contrast, CRRT removes solutes in a slow rate for a long time, stimulating proper renal function. It represents less stress to cardiovascular system. Peritoneal dialysis is not used in critical care. Indications for dialysis in the ICU are fluid overload resistant to diuretic therapy, profound metabolic acidosis refractory to medical management, hyperkalemia refractory to medical management, uremic symptoms or signs, poisoning with a dialysable drug or a toxin, electrolyte derangements in the setting of AKI, progressive azotemia or oliguria without response to medical management, or hypothermia refractory to regular cooling techniques. Dialysate is a fluid that is pumped into the filter canister surrounding the hollow fibers. Diffusion gradient is determined by the concentration of solutes within dialysate. Dialysate contains sodium, chloride, and magnesium levels that are similar to serum concentration. Their removal is observed only in case if the blood level exceeds normal concentration. Potassium 2 or 4 millimoles per liter in CK dialysis, bicarbonate 20 millimoles per liter in CK dialysis, glucose, and sometimes in addition phosphate and calcium. On this slide you can appreciate components of citrate solution and dialysate used in CVVHD. CRRT access depends on the type of dialysis technique and duration of renal replacement therapy. Dialysis catheter has usually two lumens. The first lumen is pulling blood from the patient, is usually marked with red color. In contrast, the second lumen is reinfusing the blood into the bloodstream. It's usually marked with blue color. So how does it work? External kidney is enclosed canister with a lot of hollow tubules called hollow fibers. Hollow fibers are made of semi-permeable membrane. Area of CVVHD filter is usually 1.8 square meters. It's determined by two compartments. First, blood compartment and drainage compartment, which can be filled with flowing dialysate or can serve as a waste or surplus water drainage. What are the principles of CRRT? You need to be aware and understand the term diffusion. Diffusion is a movement of particles across semi-permeable membrane from the side with higher concentration of particles to the side with lower concentration. The only force that makes diffusion possible is concentration gradient. The bigger the concentration difference of particles in solute is, the bigger will be the force of diffusion. It's effective at removal of small molecules. Substances less than 20 kilodaltons can be removed. Amounts of liquids on both sides of membrane is constant. Depends on the concentration gradient, membrane permeability, surface size of membrane, and charge of particles. Concentration gradient is enhanced with the countercurrent direction of blood and dialysate that flow against each other like in native renal parenchyma. Ultrafiltration is a movement of water across a semi-permeable membrane due to a pressure gradient, difference of solute pressures between two compartments. The difference between the blood pressure in the hollow fibers and surrounding pressure is called transmembrane pressure. that determines the ultrafiltrate production. Ultrafiltration depends on TMP, surface size of membrane, and hydraulic permeability of membrane. Ultrafiltration is connected with another physical principle, convection. Convection is the transport of a solute across the membrane along with solvent by so-called solvent drag, a collective movement of molecules within fluids. Solute molecule is swept through a membrane by a moving stream of ultrafiltrate. Convective transport is independent of solute concentration gradient across the membrane. Positive pressure is generated in the blood compartment by increasing the hydrostatic pressure in the blood compartment, increasing the rate of blood flow to the membrane, and negative pressure in the dialysate compartment that facilitates ultrafiltration created by decreasing the oncotic pressure of plasma by pre-dilution. It's useful for small and middle-sized molecules clearing. Also, middle-sized molecules, such as mediators in sepsis, are removed. Hemofiltration technique enhances the loss of water, causing hypovolemia. Any water removed must be returned to the blood via the replacement fluid. Replacement fluid is present only in CVH and CVHDF. Replacement fluid is sterile. Electrolyte levels are similar to plasma. The fluid can be replaced pre-filter or post-filter. This table summarizes advantages and disadvantages of pre-dilution and post-dilution. How is it with anticoagulation? CRRT can be either anticoagulation-free, regional with heparin anticoagulation or citrate anticoagulation, or systemic. No anticoagulation is indicated in patients with a high risk of bleeding. Impaired hemofilter survival can be prolonged by diminishing hematocrit within the filter by pre-dilution, maintaining a filtration fraction less than 20%, and achieving high blood flow rates. It's indicated for patients on therapeutic anticoagulation for another indication. Nonetheless, regional citrate anticoagulation is the first choice in ICU. In regional heparin anticoagulation, there is a pre-filter infusion of unfractioned heparin, and post-filter neutralization is represented by protamine. There is shorter hemofilter survival compared to regional citrate anticoagulation. Regional citrate anticoagulation decreases the risk of bleeding, and it's also prolonged hemofilter patency. In contrast, there is a risk of electrolyte disbalance, risk of metabolic alkalosis or metabolic acidosis, and when trisodium citrate is used, there is increased sodium load to the patient. How does the citrate anticoagulation work? Citrate is a calcium chelator. Ionised calcium is important for proper function of coagulation cascade. Calcium bonds on clotting proteins. Decreased level of ionised calcium leads to inhibition in thrombin formation. Citrate is a strong anion and is administered mostly in a form of trisodium citrate to minimize ion differences. We need to be aware of citrate toxicity, as some proportions of infused citrate is removed by the CRRT circuit with bonded calcium ions. The rest of citrate calcium complexes return into the bloodstream and undergo metabolization liver, kidney, and muscles. Bonded calcium is released. Citrate is then transformed to 3 bicarbiones. In patients with normal liver function, we can subsequently observe metabolic alkalosis. In this case, we can either decrease blood flow or increase dialysate flow. In patients with liver dysfunction, we can observe metabolic acidosis. In this case, we can decrease blood flow, treat life-threatening hypocalcemia with IV calcium, or switch to regional heparin anticoagulation. Alternatively, we can use systemic anticoagulation. Unfractioned heparin infusion is managed if regional citrate anticoagulation is contraindicated. Heparin-induced thrombocytopenia can develop within 5 to 10 days of heparin use. Low molecular weight heparin administration lowers the risk of HIT. Low molecular weight heparin use is slightly superior to unfractioned heparin in hemofilter survival. HIT requires discontinuation of heparin, Further systemic anticoagulation is needed, either argatroban, leperidone, or danaparoid. Transmembrane pressure is hydrostatic pressure gradient across the membrane. Rise of TMP is gradual throughout the life of a filter membrane. Sudden rise of TMP with normal value of return pressure signify clotting. The limit of filter is approximately 450 mm mercury. Filtration fraction is a percentage of plasma that is being removed from blood during ultrafiltration. Filtration fraction above 25% can lead to increased risk of clotting. For diminish, we can either increase pre-dilution rate or reduce replacement pump rate. SCUF, slow continuous ultrafiltration, is rarely used in ICU. It's carried out with high flux membranes, and the objective is to achieve volume control in patients with severe diuretic-resistant volume overload by ultrafiltration of excess fluid without metabolic imbalance. Because of low filtration rates, this method is not so effective as the blood purification modality. Its indications include fluid removal without significant electrolyte imbalance. CVVH, continuous veno-venous hemofiltration, is rarely used in ICU. It works on the basis of convection and ultrafiltration. Convection is used for the purpose of clearing wastes by removal of large amounts of fluid across the filter membrane. The volume of removed fluid is greater than surplus water, hence must be restored via replacement fluid. The amount of fluid in the effluent bag is equal to amount of fluid removed from patient plus the volume of replacement fluid administered. Indications include uremia, acid-base imbalance, electrolyte imbalance, or need of large molecular weight particles removal. CVVHD works on the basis of diffusion and ultrafiltration. CVVHD is the most frequently used method in ICU. Removal of waste is caused by diffusion. Countercurrent dialysate flow mechanism enhances the concentration gradient, hence there is a greater clearance. The dialysate determines what type of solute is going to be removed by its own concentration of solutes. If concentration of some particle is higher in dialysate, this particle will diffuse into bloodstream. Indications include uremia, severe acid-base disbalance, or severe electrolyte-base disbalance. CVVHDF, continuous veno-venous hemodial filtration, is rarely used in ICU nowadays. It works on the basis of convection, diffusion, and ultrafiltration. This technique uses both modalities, dialysis with diffusion and hemofiltration using convection. This therapy includes replacing the fluids through the pre-dilution or post-dilution and the dialysate solution. Canister divided into two compartments by semipermeable membrane has one side with high concentration and pressure of solute and the second with low concentration and pressure, thus maintaining the concentration gradient for dialysis and TMP for ultrafiltration. Circuit can be altered for CVH by removing the administration of dialysate or for CVHD by removing the administration of pre-blood pump fluid and post-dilution replacement fluid. SLED is sustained low-efficiency dialysis. It's a hybrid technique of renal replacement therapy that proceeds from intermittent hemodialysis and CRRT. It requires 6 to 12 hours to run a day, which can be done overnight. It offers significant breaks between treatments and mobilization of patient, so diagnostic and therapeutic work can be done. Urea clearance is 80 ml per minute versus CRRT, in which is 30 ml per minute. Patient can profit from the shorter duration of exposure to anticoagulant. Otherwise, saline flushes can be used instead of anticoagulation drug or citrate solution. SLED offers faster removal of wastes and lower cost compared to CRRT. It might be 3 times cheaper than CRRT. In contrast, we can observe worse hemodynamic stability after the procedure, but it's still better than intermittent hemodialysis. Once deciding on the modality of choice, a dose must be chosen. A dose of effluent flow rate in milliliters per hour. It's a flow rate of ultrafiltrate and dialysate together, and effluent dose calculated in milliliters per kilogram per hour, which is normalized effluent flow rate to patient body weight. The dose of CRRT can be thought of as the volume of blood purified per unit time. Typical dose of CRRT is 25 to 30 milliliters per kilogram per hour. It's calculated as ultrafiltration rate in CVH, delivered dialysis flow rate in CVHD, and both for CVHDF. Higher dose haven't found no significant difference for mortality or rate of renal recovery. These patients with more intensive CRRT had significantly higher rates of hypophosphatemia. Furthermore, receiving high doses of CRRT decreases the plasmatic concentration of several drugs in bloodstream, e.g. antibiotics. How to prescribe CRRT? CRRT dose is quantified by the effluent dose, 25 milliliters per kilogram per hour. How is it with blood flow rate and dialysate flow rate in CVHD? Dialysate flow rate is calculated as blood flow rate times 20. Blood flow in a patient with 80 kilograms is usually 100 milliliters per minute. Dialysate flow rate in this patient is then 2000 milliliters per hour. CVH and CVHDF are nowadays rarely used in ICU. Bicarbonate buffered solutions are preferred over lactate buffered solutions. For RCA, we always use calcium-free dialysate. Fluid removal depends on clinical situation, such as pulmonary edema, etc. We avoid very high ultrafiltrate rates. This is an overview of original citrate dialysis. We administer citrate solution before the filter. Citrate binds to calcium. Dialysate flow, which is running into counter direction to blood flow. Effluent is containing citrate and calcium. Behind the filter, we administer calcium infusions. And you can also observe that there is still some citrate remaining that is returning to the bloodstream of the patient. So how do we prescribe citrate CVHD, which is the most frequently used method of CRRT in ICU? In an 80 kilogram patient, we usually start with dialysate flow rate of 2000 milliliters per hour, blood flow rate 100 milliliters per minute, citrate dosage is 4 millimoles per liter, and calcium dosage is 1.5 millimeters per liter. In a patient with 100 kilograms, we usually start with 2400 milliliters per hour dialysate flow rate, 120 milliliters per minute of blood flow rate, and citrate and calcium dosage is the same. The white arrow points on a site from which we withdraw samples for determination of post-filter ionised calcium. We adjust the citrate dose depending on the levels of post-filter calcium as displayed in the table. Moreover, we also need to focus on systemic ionised calcium levels. We adjust the post-filter calcium rate depending on their levels. How can we affect acid-base balance in CVHD? Horizontal axis represent Zika dialysate flow in milliliters per hour. Vertical line represents blood flow in milliliters per minute. The numbers from 30 to 18 represent expected concentration of bicarbonate in serum in millimoles per liter. To correct an acidosis, we can either decrease the dialysate flow or increase the blood flow rate. Whereas in patients in alkalosis, we can either increase the dialysate flow or decrease the blood flow rate. Finally, what are the general complications of renal replacement therapy? Complications related to access, such as bleeding, vessel damage, bloodstream or localized infection, or air embolism. Respiratory complications include hypoxia or hypocapnia. Circulatory complications include hemodynamic instability or hypothermia. Neurological complications are represented by dialysis disequilibrium syndrome. Also, we can observe gastrointestinal complications such as malnutrition. Moreover, there could be renal, electrolyte, or hematological complications. Thank you for watching Prague ICU and stay tuned for next interesting educational videos.